today's Quality and Patient Safety Committee meeting. Pursuant to the Illinois Open Meetings Act, meetings held remotely will require roll call votes for all action items. To streamline, we've combined the action items into one combined motion, so only one roll call vote for action items will be needed during this meeting. I'd like to call the meeting in order and ask Madam Secretary to call the roll.
Director Garza?
Present.
Director Prendergast?
Present.
Director Story?
Present.
Chair Kim?
Present.
And for the record, those directors also present. Director Sam Robinson, newly appointed as of yesterday.
Present.
Welcome.
Thank you.
Thank you. You have a quorum.
Thank you. I'd like to also point out that our next committee meeting will be on Friday, November 18th at 10:30, so I look forward to seeing everyone there. I'd like to know if anyone registered for public testimony. This will be done virtually or written testimony that should be included in the record. Madam Secretary, do we have anyone?
We did not receive any registrations for virtual testimony, nor did we receive any written testimony.
Thank you. Okay. In terms of the report on quality and patient safety matters, we don't have any action items needed for this item. This is only for information. Everyone should have received those packages by email. We're going to start with an HRO dashboard review by Dr. Mikiadis, the Chief Quality Officer.
Good morning, everyone. So we will run through these slides. Can we move to the next slide? Thank you. We will start with our readmission report. So this is our 30-day unplanned all-cause readmission to Stroger Hospital. Well, we saw a slight increase from 7.49% to 8.33%. On our overall readmission rates, we continue to perform better than target. Year to date, through June 30th, our 30-day unplanned all-cause readmission continues to average around 9.77%. The readmission team continues to focus on their heart failure readmissions. And although we had an increase over the last month in our 30-day heart failure readmission rate, our 7-day rates remain stable at 3.1%, driven primarily by the following efforts. Follow-up appointments are being requested upon admission instead of waiting for discharge, which has driven our turnaround times to scheduling to less than 1 day and has contributed to appointment delay times going down from 30 days to 17 days. Cardiology appointment show rates are also being monitored after a push for early scheduling process changes, as I mentioned, and patient education on the importance of follow-up. It's contributed to show rates increasing from 42 to 48%, and more recently we've seen spikes up to 60% on show rates post-discharge. The cardiology team has also increased their number of slots available the week after discharge, which has allowed 50% of discharge patients to be seen within 7 days and 80% within 14 days. Our pharmacy consults are being done now with 2 pharmacy students on rotation. They're doing post-discharge calls, and we've also brought our charge nurses on Tiger Text, which is allowing our pharmacy team to communicate better with the floor teams when medications are ready at time of discharge. In July, our transitions of care nurses were also added to Tiger Text, which allowed for easier access for patients to communicate with the transition nurses as well as the physicians. They're now able to connect via text and can intervene earlier post-discharge, which allows them to potentially avoid a return to the emergency department. And more recently, 2 additional transition nurses have been added. They are now going to support COPD and asthma patients, both at the bedside and post-discharge with phone calls. And on the horizon, additional diagnoses are being explored, including renal failure, hematology, oncology diagnoses, and CT surgery-related diagnoses. Next slide, please. So the first of the 2 case mix index reviews is for medical. So our medical index decreased slightly from June to July from 1.27 to 1.24, which is right at target, just below stretch. That spike we see in January was very much attributed to the COVID volumes that we saw over the winter. We saw about a 20% increase in our case mix with COVID patients just due to the severity of illness. Our CC and MCC, so comorbid condition and major comorbid condition capture rates with our medical DRGs are at predicted goal. They did decrease slightly from June to July from 66% to 65%. Next slide. Moving to surgical, we did see an increase June to July from 2.77 to 2.96, and we're trending towards goal. The capture rate for surgical DRGs dropped a little bit from 66 to 64% June to July, slightly below target, but still within predicted performance range. The clinical documentation team is targeting specific service lines, trauma, ICU, and cardiology with physician education and working with our CDI specialists on physician queries. Just a little bit of that background CDI data in July. They sent 196 physician queries with 93% response rate and 96.7% agreement rate. Next slide. Patient experience. So this is our top box score for recommend the hospital HCAP surveys for Stroger. Likelihood to recommend for Stroger increased July to August from 67% to 71.5%, getting us back to target. Lynn Dang is leading the effort to implement standards of behavior, which we're calling CI Care, as well as bringing online on-the-spot recognition and service recovery programs for our staff. Next slide. And our last slide for this presentation is our diabetes control. So we look at our A1C percent of patients greater than 9%. So we're looking at our in-care patients, which is defined as 2 clinic visits within the last 2 years. And we see that A1C is greater than 9%. Measure continues to trend in the right direction. We're down to 24.7% above 9% A1C in August, and that marks a full 4% reduction from our high in February. And we're zeroing in on the goal of 24%, which would reflect top decile performance in this measure. Dr. Irons, Beth Vaklovic, and Madi Ferrer are HEDIS ACHN triad. They're working with physician and operational leads in the ambulatory setting to improve processes, and they're actually going to be presenting a little bit more today about their work. And then I think our last slide is definitions.
Thank you, Dr. McYaddis.
Thank you.
I don't see any hands raised. Great progress. I'm going to turn this over to Leslie Frayne, the Associate Chief Quality Officer, who's going to give us an update on regulatory and accreditation.
Good morning, everybody, and welcome, Chair Kim.
Good morning.
For regulatory updates, we have no survey follow-ups at this time. We have a lot pending. I'll go through these since we have some new members. We are in the window for our strokes certification survey. We have consultants here from QHR who hosted a mock in April, and they actually are scheduling a second mock at the end of this month. And following up on those action items. Our window is open in July, so this is a survey that we actually get the date for, though, so it's not unannounced. So I have not received that notification yet from the Joint Commission. We're also due for an extension survey for our MRI over at Provident. This is a one-day unannounced survey, and it is expected after November 7th. We've done approximately about 15 MRIs there now, so we can expect them to come out and do a survey. And we also had QHR perform a mock. They had their second one on October 4th of this month, and action items had been sent out to all the leaders for follow-up. We're also expecting an extension survey from Joint Commission at Belmont Cragen. Again, this is a one-day unannounced for the opening of that survey. Date is to be determined, and again, we had QHR do a mock there on August 25th, and the action items, I believe they're all followed up on. We should be in pretty good shape there. We are going for a Stroger trauma designation survey. This is voluntary, so our date is to be determined. We are not going to do it till we feel like we are ready. We did start preparing back in February of this year. And then we have a Provident extension survey for inpatient dialysis surveys that started actually on October 11th. So I did notify the Joint Commission of that, and then they are expected to come out and do a survey for inpatient dialysis. And what I don't have on here, no survey, but we did start our ambulance runs over at Provident this week. So great to see that. Any questions? Thank you.
Thank you for those updates. I'm next going to turn the floor to Dr. Bina Peters, the Chief Nursing Experience, who's going to give us an update on our quarterly nursing operations.
And Chair Kim, this is Debbie.
Yes.
Just stating for the record, Director Harrington has joined us, and also non-director member Pat Merriweather is with us.
Great, thank you.
Good. Thank you, Director Kim. Good morning, Board of Directors. Bina Peters, the Chief Nursing Executive Officer for CCH. Just want to share the nursing priorities since, based on the 2019-2022 CCH strategic planning that focused on providing high quality and safe care, zero harm initiatives, which is zero harms to the patients and the staff, efficient and effective care delivery model, workforce planning, improve patient experience and staff engagement. So these are the priorities we set in 2019, and we continue to focus on those priorities. Next slide, please. And also in 2019, to drive these priorities, the nursing across the system came up with a Department of Nursing guiding principles that we will be using to improve, to make decisions on nursing, processes as well as the policies. So again, come up with a patient-centered model, shared governance structure that is giving a voice for the frontline nursing staff on their practice, their culture of clinical excellence, a culture of accountability, just culture, teamwork, collaboration with the healthcare partners, improve efficiency, evidence-based best practice, and commitment to lifelong learning. So those are the guiding principles established in 2019, and we continue to hold them to our heart to make the decision for the nursing and the practice of nursing across the system. Next slide, please. So this is or when we looked at it, the nursing quality is measured by nurse sensitive indicators. So we focused on the top 5 nursing quality indicators since 2019, and one of them is hospital acquired pressure injury. And so this is the story where when we started this journey of hospital acquired pressure injury reduction initiatives, we decreased it an 87% since 2019. Our goal was to reduce it by 50% and a stretch goal of a 60% in 3 years. So we exceeded both goals and the stretch goals. Now, I'd like to share the journey where this is a true kudos to our frontline staff, the frontline leaders, which this become the priority, and they focused on all the incident, 100% review of all hospital-acquired pressure injuries. That helped us to learn the why behind it. What are the barriers to provide safe care to our patients? We listen to our frontline nurses, and truly this become the ownership of the entire nursing staff in acute care setting. And this is the report for Stroger, because Stroger Hospital is the one reported at the national benchmark. What does that mean to the Cook County Health System? So each falls with the or hospital acquired pressure injury has an average cost of $43,000 per incident. That is the national average cost. And also, as a healthcare across the country spend more than $2.3 billion to address the HAPI. So what that mean to Cook County? So all these initiatives help us to have a cost avoidance over $12 million in the last 3 years. And also this improvement placed Cook County Health System, Stroger Hospital at one of the top performing hospital in the country based on the NDNQI. NDNQI is a national database for nursing quality indicators. Over 1,500 to 2,000 hospitals systems report their data to this group. Next slide, please. Also, the next indicators we focused was the patient falls and the falls with injury. There are a number of activities actually is happened in the last 3 years, process improvement initiatives to look at the falls with the injury incidents, and the process improvement initiatives, again, bringing back these goals and objective to the frontline staff and hearing their concerns as well as addressing the barriers, help us to reduce a total falls 59% since 2020 and a 67% reduction of falls with injury. And what happened in 2019? We will be looking at the structure, creating a structure to report 100% false, and the data was not accurate to report. But I think 2020, we got that structure in place and a significant collaboration again between the nursing staff, frontline leaders, as well as other healthcare team within. What that mean to Cook County Health, right? That also took us to one of the top percentile performers in the country for the benchmark. Lower is better. So we are below 10 percentile for the total falls. We are in between 25 and the 50th percentile for the falls with injury, even though we saw a 67% reduction. So we are looking at to see, what are the causes of those falls with injury. So lots of work is being done by the team to improve and achieve both falls reduction goals as well as the falls with injury goals. There are, this number of studies shows that the hospital falls cost, an average cost is around $14,000 per incident. That also the falls reduction initiatives help us to contribute a cost avoidance of approximately $11 million for the last 3 years. Next slide, please. The other area of focus for the central line associated bloodstream infection. This is a true.
Madam Chairman, could I ask a question about the falls before we go on?
Absolutely. Director Story, is that you?
Yes, ma'am.
Okay, yes, please.
Dr. Peters, with respect to the number of falls, do our inpatient beds have alarms, or is there some device that those patients who are at risk for falls, is there something that's on them? Do we have any technology that supports the reduction that that nursing has achieved?
Yes, we do have the birds with the with the false alarm birds that is connected to each bird. We can activate it. And a new process we implemented was that the chairs also we are added the alarms, so that way a patient sitting in a chair, that will help us to communicate that to the nurses. Number of work is being done in that area, Director Story, because previously the false alarm or the bed with the false alarms, the noise, the audible alarm was only at the local level. We are connecting that to central nurses station, so that anyone who can hear this, the alarm can respond to it. So number of activities being implemented, part of the technology optimization to achieve the goals.
Thank you.
Thank you, Dr. Story. Next slide, please. So another focus area was also CLABSI, which is central line associated bloodstream infection. That also we achieved a 42% reduction since 2019 to 2022. This is truly a strong collaboration between the nursing team as well as the infection control team. Again, we are looking at, we are reviewing the incidents and understand the barriers, same principle, process improvement principles. However, we are seeing a slight increase in our CLABSI rate based on the annualized numbers. So we actually are looking to understand the why behind it, because last year we had 7 CLABSIs and this year we have 6. But we wanted to prevent first to go towards our annualize the numbers. Our goal is to keep below last year numbers. So that's the focus currently on between nursing team as well as the infection control team to understand, how to prevent the incidents in the future, coming rest of the year. For that way, we are below the national benchmark. Also, we do monitor this part of the NDNQI. You can see for the last 3 quarters, For the last 3 quarters, we did below the benchmark, but however, there is a slight increase based on the national benchmark. So lots of work is being done under this area of improvement to make sure that we will be one of the best performing hospital in the country. Next slide, please. The other areas is catheter-associated urinary tract infection, and also you see the trends going down, a 42% reduction. And part of the Class C reduction, there are two nurse-specific intervention. One is the protocol on the catheter removal, so that way a nurse can make the decisions based on the criteria to remove the catheter timely to avoid the long line day, long catheter days. And also we implemented an external device per week for in replacement of the catheter. So we are seeing the improvement, and this is also area for focus to make sure that we sustain the improvement as well as decrease further. Next slide, please. Restraint utilization also is part of the nurse sensitive indicators where this is a prevalent study. We looked at the number of patients restrained during the prevalence time and report the data to the national database of nurse quality indicators. We consistently perform or outperform the average, and actually we are one of the top performing in the country, which is below the 10 percentile. Lower is better for this indicators. Next slide, please. The other focus area for us is sepsis prevention. Of course, sepsis is not just the nursing-driven initiative. This is the system-driven initiatives, and specifically to the nursing. We looked at the response time to sepsis alert. Our goal is to establish an alert, and communicate the alerts to the providers for intervention is less than 15 minutes. And that is the focus. And you can see that our goal was to achieve an 80%, and we are there. However, lots of work is being done with in collaboration with the chief quality officers and also the providers to really look at the entire process of sepsis prevention initiatives to improve the outcomes. Next slide, please. The other initiatives include for us to really look at the hand hygiene observation. The LeapFrog score has a specific indicator for us to report the hand hygiene observations to the database on a monthly basis, which is a 200 observation per unit. So this was an initiative we started in 2021 May, where we were at close to a 60% compliance, and then since June we continuously meet the goals or exceeded the numbers. And these are the observations. However, we are also looking at the complaints rate at the unit level to make sure that we meet a 90% goals to as all of us perform the hand hygiene prior to the interventions. Next slide, please. Also, nurse communication is part of the patient experience, and patient experience score has a significant impact on our external rating as well as the patient's, improvements, safety. So we focused on nurse communication. Lots of work is being done under the leadership of Dr. Witten at the Stroger hospitals to really look at some of the barriers to improve nurse communication. And you can see we are seeing a notable improvement. So we reached to a 74.19 third percentage of satisfaction within nurse communication. That took us to a 23rd percentile. This is the area we are working, not only to improve and also sustain the improvement. So lots of work is being done also in this area. Next slide, please. So just kind of see lots of work with the CCH, and I'm also seeing a lot of, so we are able to sustain the improvement. I just want to share a national trend. This slide is from the Preskeni, which is a national, data. They manage the NDNQI as well as the patient experience for us. So there are significant reduction in safety culture, the patient safety outcomes, and workforce safety and safe and equity across the country. A 7% reduction in nurse sensitive indicators were noted throughout the country through the database. So the quality, the pandemics impacted the quality. So as nationally, everyone is saying. Next slide, please. So even though, Pat, Director, any questions? No, sorry. So even though there are significant challenges to the health system across the country due to the pandemic related to the staffing, high use of agency, you see that if you use more than 15% of the agency staff percentage, there are studies to show that quality can impair, right? So anyway, with the national trend, lots of focus from the nurse leaders. I know we have more than 15% agencies to truly focus on quality. And with the efforts, everyone, frontline nurses, the frontline leaders, and a true collaboration really help us to not to be part of that 7% decline in the overall nurse sensitive quality indicators. We in fact improved as well as sustained. This is the summary. We decreased the falls with the injury, decreased the happies, the CLAPSIs, and the CARDIs, and increased the star rating for the health systems, medication scanning. So if you look at all the aspect of the priorities, we said we have a notable improvement, and we will be closing the this new new strategic plan. So this is kind of the summaries to show that improvements are sustained, and we continue to work on those things. Staff engagement. We started a staff retention committee with the frontline staff. So lots of work is being done, and we continue to do that. Next slide, please. As I mentioned, we have a nursing retention committee. We initiated the nurse residency program, which is one of the best practice in the country. The new nursing graduate turnover was decreased by 86% with the nurse residency program. That is being out there for a nursing world for over 10 years. We implemented this program at Cook County last year, and the new batch of new residency program nurses graduated in summer with the evidence-based practice project. So that's really looking at it. We also have an APR and transition to practice program, which we received the HRSA grant, really helped the bedside nurses to prepare them to be a provider and be an APR. So I mentioned we also have nursing retention committee initiated. We are working closely with the HR to get the nursing turnover data at the unit level so we can really understand the why and see what else we can do. So these are all the actions in motion to really look at the nursing retention rate as well as efforts for really supporting our nurses to provide safe quality care. Next slide, please. So kind of shared with you nursing workforce optimization. Also, there are a number of staffing challenges like any other hospital system. It is known nationally, but these are the specific actions we are building or we built in the past to really create a flexible staffing pool, because currently when we have increased volume and acuity, we don't have a strong flexible staffing pool. So we are in the process of building. We have patient care support nurses that is part of the new CBA, which help us to address some of the nursing care gap during the peak time and increase the in-house registry pool as well as create a structure for agency management. We are also working with the other nursing schools to plan the future strategy for the nursing workforce. Currently, we are working with the Loyola, where the new program, the nursing students will complete all their rotations with the Cook County all 4 years. So they are become part of it with the hope that we can recruit them. We also started a nursing externship program. That means in this program, we are recruiting new nursing students or the nursing students on their 3rd and the 4th year of their school to be part of this program. Again, these are the strategies to build the future workforce to address the nursing shortage. Next slide, please. Thank you. This is the summary of quarterly nursing update. Any questions, comments, suggestions?
Well, I want to just say, Dr. Peters, thank you for your leadership and thank you to the staff. Things are heading in such positive directions, and I commend you for your innovation and progress.
Thank you,
Madam
Dr. Kim.
Chairman, I have a couple of questions I would like to ask Dr. Peters real quick.
Sure.
Is it possible for you to go back to the hand washing slide?
Yes, we can.
It was
Which,
so small.
I'm sorry, which slide was it?
The hand washing slide. Let me see whether I
Oh,
have them.
okay, hold on.
There.
Thank you.
Yes?
Yes.
I was just concerned about the fact that the operating room was at 200
Yes.
and the pediatric ICU in areas where there's,
Yeah.
well, I would think that hand washing would be most critical in the operating theater where we are eviscerating, opening up patients, and where there's an easy access point, right, into the body for infections. So I was really concerned that of all departments would have one of the lowest.
Yeah.
ratings.
Thank you. Excellent question. Let me clarify this slide, Director Story. These are the number of observations. These are not the compliance. We are
Okay.
required to do a minimum of 200 observations. And in here, you can see some of the units, they love to do more observations. So really, these slides show us, are we meeting the minimum standard of the observations per unit? And this shares, and this report goes part of our leapfrog. So we track this monthly. And the compliance slides, we can add the compliance slide to the next presentation. That varies between the units, and that's what we are working. And I think you are looking at the compliance versus the number of the observations. I think that's my takeaway, Director Story.
Well, thank you. I still would find that rather curious, even on this observation slide,
Yeah.
that of all areas, seem like this will be the greatest concentration
Yeah.
in dialysis where people have, you have open access
Yeah.
to the
Yep.
body cavity. So I'm just
Thank you.
concerned about that.
Thank you. So the feedback, we'll take the feedback to the group and take a look at it to increase the observation on those prime areas. Thank you.
Director Story, do you have any other questions before we move to others?
Leslie, can you tell us when the leapfrog scores, the most recent leapfrog, what was our most recent leapfrog score? And when will the next report out from leapfrog come?
Our most recent leapfrog score is a C. And we will be getting another score in the spring.
In the spring.
Right.
What about the Press Gain survey?
Which
For
prospect? Go ahead, Leslie.
Are we still participating?
For HCAPS, for our hospital, Press Ganey, our patient scores? I'm not sure what you're referring to with Press Ganey.
I thought that we were involved in a couple of Press Ganey surveys, one been with the employees and one been tied to our quality.
Okay, so you're talking about employee engagement. Yes. That survey we just took. I believe it closed just a couple weeks ago. So we are waiting on our results. And with embedded into the employee engagement survey is our culture of patient safety survey. You are correct. So there's, I think, 14 or 17 questions that are related specifically to patient safety. And, we'll take those out and they are scored separately, but they are embedded in the employee engagement survey. So those were both just taken this year and closed a couple weeks ago. So now we're waiting on Press Ganey to compile our results. As soon as we have them, we'll report them out here to you.
Thank you, ma'am. Those are my two questions.
I see.
This is Ling. Sorry, I just want to let you know that Press Ganey will not be able to give us the results until November 17th, just so you'll have that. in your back pocket.
Oh, that's a great day. I won't forget that day.
Is it your birthday? Is that why you won't forget that date?
Well, the budget is also, Cook County's budget is approved also, but my birthday just happens to fall on the 17th.
Oh, okay, we'll remember that.
But the budget is the most important thing, the county budget.
I see Pat Merriweather and then Director Harrington have their hands up. So Pat.
Yes, again, I want to echo that. I think it's the compliance scores that are most important for the hand hygiene. And I agree that some of the areas that are more susceptible to open wounds and that really need to be addressed. I also know that I'm pretty sure the leapfrog scores are coming out in November. That's typically they do in November and a spring release. And I haven't seen that they've pulled back on that. So we should be getting a score out there soon.
Yes, we should be getting our score soon. And I think I missed a slide here. Debbie, can you go back? There is a leapfrog slide. I thought we had it here. So maybe I missed it. Yeah, this is, I think I missed the slide. So this is the slide to show our trend in our leapfrog. We started with a D, then to an F, C, and a D. So we have 2 C's in a row, and we do strongly feel that we will not go back. I think the indicators, our outcome demonstrate that we will see our reports will tell the story.
And I agree, the pandemic did set us back in many safety areas. There were many reports written by CDC and CMS that showed that the nation did take a couple of steps backwards. And I was just wondering on current staff and staff that have been in place before, the type of re-education that will be going on.
Yes, the gain, even though, the pandemic does, decrease our overall, the safety indicators for nationally, we do, have an ongoing education program for the staff, especially the agency nurses onboarded, so that totally understand our priorities as well as the expected action. So that is part of our monthly and bi-weekly onboarding process with the staff, as well as the annual competencies of our nursing staff for the system.
Okay, thank you.
Thank you.
Director Harrington?
Yes.
There.
Yeah, my question gets back to the hand washing. I just want to know who's doing the observation. Is that your staff, or is it someone in that unit that's doing the observation?
It is the combination of staff doing the observation. It can be infection control, staff, the nursing staff. We also have some staff with some light duty where they are not able to, do the full nursing duty. So we also assign them. So it's a variety of team that's participate in the hand hygiene observation task.
Thank you.
Thank you, Dr. Harrington.
Thank you again, Dr. Peters. We're going to move on to Dr. Sharon Irons, the Medical Director of Ambulatory Services, who's going to give us the HEDIS report.
Good morning. I'm going to speak about 2 metrics that we've been tracking very closely. The first is the hemoglobin A1C greater than 9 measure, which was mentioned earlier. And to place this into context, when a diabetic patient has an A1C that's more than 9, it means that their diabetes is poorly controlled. Therefore, our goal is to have a low percentage of patients with an A1C greater than 9. Again, the lower the percentage, the better. Before the year 2020, our target was set at having 32% or less of our patients with a hemoglobin A1C level greater than or equal to 9. As a system, we hit that benchmark in the year 2020, which meant that we were doing better than 75% of other healthcare organizations. Therefore, we set the new target at the 90th percentile, meaning that we aspire to be in the top 10% of performers in the country. At that new 90th percentile benchmark, our goal is now to have 24% or less of our patients with an A1C level greater than 9. So this slide depicts the second quarter data of this year. And as you can see here, by the end of the second quarter, 7 out of 12 of our health centers had met the goal. And I'm happy to report that the data coming in for the third quarter, which is the end of September, is showing that 9 out of 12 of our centers have now met that goal. So as of today, only 24.5% of our diabetic patients have an A1C level of greater than 9. Next slide, please. So this next slide is a report of our second quarter data for childhood immunizations. On this metric, we've also had substantial improvement compared to last year and compared to the first quarter of this year. Our target is at 73%, which is a 75th percentile benchmark, meaning that if we meet the goal of having 73% or more of our children fully vaccinated by the age of 2, we will have obtained the status of doing better than 75% of other healthcare organizations. So here again, I'm happy to report that our health centers have been doing a really great job in moving the metrics in the right direction. As a composite for the health system, at this time last year, we were at 56% of our Cook County health patients having received the age-appropriate vaccinations. This year, by the end of June, we are at 66%. As depicted on this slide, our top performer is Belmont Cragen, and they far exceeded the goal, and they have reached at 85.7% of their patients as of the end of the second quarter. Also, as you can see here, the Core Center and North Riverside clinics have also met the target of 73%. And I will say the data that we have now pulled for the third quarter coming in is showing that 5 out of our health centers are now meeting that goal. 5 are trending between 60 and 70%, so getting close to the 73%. And on only 1 of our centers is less than 50% at this point. Next slide. Thank you. So basically, this next slide demonstrates the A1C, hemoglobin A1C, and the childhood immunizations, in addition to 3 other metrics that we have recently started prioritizing as focus areas. These were all chosen as focus areas due to the significant effect that improvements would have on the health outcomes of our Cook County Health patient population. So reviewing this slide, you can see that for breast cancer screening, we were at 51.8% for age-eligible women, meaning that at least 1 mammogram had been performed on these patients within the previous 2-year period. By the end of the second quarter, we were at 52.4% of women screened, and now data that's coming in now is showing us that we are at 55%. And again, that 75th percentile benchmark nationally is at 59%. For childhood immunizations, the 75th percentile target is at the 73%, as I discussed. By the end of the first quarter, we were at 59.5% this year. At the end of the second quarter, 66%. And recent data is showing that our third quarter numbers are coming in at 69%. For the hemoglobin A1C greater than 9, the target being 24% at that 90th percentile. At the end of the first quarter, we were at 26.2%. At the end of the second quarter, 24.7%. Now at the end of the third quarter, we are at 24.5%. So we are almost there. And again, this is an inverse metric, so we want that percentage to be low. For hypertension, which is a metric that looks at blood pressure control in patients aged 18 to 85, we want a blood pressure that is less than 140/90, and the 75th percentile benchmark is having 62.5% of patients with a diagnosis of hypertension having that level of control, less than 140/90. We were at 48% at the end of the first quarter, 53% at the end of the second quarter, and currently we are coming in at 55% control rate. For cervical cancer screening, our goal is 64%, that is the HEDIS 75th percentile benchmark for age-eligible women to have cervical cancer screening. So this data is just a bit more difficult to tease out, but we are working very closely with our BI department to get the data that we need. Some of our patients have had hysterectomies, for example, and do not require cervical screening any longer. So we have to tease that data out. But as we work the data out, our baseline appears to be around 44.7% now. So by my next report, I should have updated information. And then finally, next slide, please. For all of our metrics, we have a standardized PDSA approach now. So we've kind of had a comprehensive model that we're looking at across all of the metrics here. So I just want to point out that, so number one, we have co-leaders for each of the metrics or health outcomes that we're tracking. There's a medical leader and there's an operational leader. And we believe that this allows a more comprehensive approach to our implementation strategy. There's also a triad that has oversight of all of this and is in charge of our HEDIS steering committee. That includes myself as the medical director, Elizabeth Baklovic as the ambulatory nursing leader, and Marty Ferrer as the ambulatory quality director. So we have here the plan being to meet with the HEDIS metric leads to finalize standardized workflows. So again, standardizing the workflows across the system so that there can be a little nuance from clinic to clinic, but we want it to be standardized overall. The HEDIS team lead co-leaders will prepare monthly data reports with updated PDSAs for each metric if they're not meeting goal. HEDIS steering committee will support the medical and operational leaders at the monthly meeting, and we will be conducting on-site rounding at each of the sites. It is important that nursing is very heavily involved, so we want to have nursing leaders at each clinic site to really oversee the workflows around these metrics. For our do part of the model, we will schedule a meeting with physician and operational leads very soon to talk about implementation strategies, because we're trending in a great direction, but we want to keep that going. We will be reviewing team lead monthly reports to provide assistance. And as I discussed, the steering committee will be meeting, and of course, we will place more intense focus on those that are not meeting goal or seem to have special issues with struggling to meet compliance. We talked about the on-site rounding and identifying nurse champions. And the way we will study this is that the HEDIS team leads, co-leaders of each of these metrics, the medical and operational lead, will assess progress across all of our teams and all of our clinics and report out at our monthly HEDIS steering committee. We will have the local leaders, those medical leads and clinic managers are supposed to review their BI dashboards and their monthly data through Healthy Registries, which is a registry report, and they should be doing that on a monthly basis and making corrections as needed. Each team will identify barriers to this new workflow process that we're putting in place. And finally, acting, the clinic teams that are not meeting compliance, our expectation is that they will address what the barriers are and create a plan of action. Each team will work together to improve their outcomes and monitor their workflows daily to see how they can be tweaked to support improving the metrics. Each team should be looking at these metrics weekly at the local clinic level, and each team will continue to plan, review, and edit their plans based on the challenges. And the triad, as I mentioned, will continue to oversee and ensure that we have nurses at the local clinic levels working with this effort. I think that's my last slide. Are there any questions?
It looks like we have both Director Story and Director Harrington and Sam Robinson.
Yes.
Director Story?
Thank you, Madam Chairman. Could we please go back to slide 4? With respect to the great work that you all are doing and the plan, do, study, and act slide. Can you, I'm particularly concerned about the childhood immunization and the fluctuation within our space. Not that I'm not concerned about the other disease entities, but childhood immunization. I mean, I see the progress, and you referenced that the third quarter look like it's coming in at 69%. But with respect to our children, I just think that we just absolutely need to be over the top. Can you speak to the progress of the, I don't want to say slow progress, et cetera, but my bias is our children, we should be at 100%.
Yes. Thank you, Director Story. We want to be at 100%. That is absolutely an important goal to hit. We are targeting the 75th percentile because we're just not quite there yet. But I will say that we have improved quite substantially over time. One of the challenges in our system is that we have, I want to say, some transient patients coming in and going out and going to other healthcare systems. So we do have some of that. That is improving, and I think that's a part of why we're seeing these numbers get better. So they're kind of like in and out of the different health systems, and this has just been the nature of what we've had as a pediatric population. But again, I will say that over the last year, we've kind of been trying to tighten that up, doing much more outreach to the patients. And I think as a result of that, we will continue to see the numbers go up. And I think, the numbers have done extremely well over the last year compared to the year before. So we want to continue to see that year-over-year improvement.
Thank you.
Thank you. I think there's another
Dr.
question.
Harrington?
I can't hear Dr. Harrington.
My question was with slide number 3. And I noticed that it was a Cottage Grove site where things continue to go down. I mean, I see other sites somewhat going up, but I was just concerned because
Yes.
their numbers trending down.
Yes, thank you so much. So we did capture that and, had interventions with Cottage Grove since that time. And again, this is the second quarter data that's being reported. The quarter 3 data that has now come in is showing that Cottage Grove has now increased their numbers to 68.8%. So they have had a tremendous increase since that time in quarter 3.
That's good to hear.
Yes, thank you.
Director Robinson?
Yeah, my question is with this same slide. I noticed a trend. If we look at the areas that are actually represented there, Cottage Grove, Inglewood, and Robbins, that seem like the bottom tier of your slide. Have you been able to ascertain as to why we see them lacking such in comparison to the others?
Right. Okay. You said Cottage Grove, Robbins, and what was the other one? I'm sorry.
Inglewood.
And Inglewood. Okay. Thank you so much. So as I indicated, the Cottage Grove numbers have improved. So we did see that lag compared to some of the other centers. And whenever we see that, we do ask for those co-leaders of that particular metric to really have more intense effort and focus with those groups, with those particular clinics. And since then, and that's why I'm happy to report the quarter 3 data has improved. I have it here in front of me now. For Cottage Grove, like I said, we're at 68.8%. Robbins is now meeting the metric at 76.2%. So they've done phenomenal work. I mean, intensely devoting time and effort to this project. Inglewood is still low at 43.5%. So we do recognize that we have to get in there and work with them more and really figure out what the barriers are. Some of it has to do with clinic staffing. I do understand they've had some turnover, but we really need to get in there and support them more. And that is what we are doing. So we hope to see those numbers start turning around soon.
Okay, thank you. And I guess the big concern is because if I think about the sustainability of the population, and if we get it wrong here, it just becomes systemic.
Yeah, I think in particular, because the ones you pointed out really are in the south suburbs, heavily African-American population. I think that as a system, we need to figure out a way to really interdigitate more into the community. I think that would probably help getting the word out more about the importance of childhood immunizations and education, maybe partnering more with faith-based organizations. I know that that's happening, but I think we need to kind of turn up the heat on that and become more intense in that effort. I think we'll probably see some movement if we work in that direction as well.
That sounds great. The example can be seen actually as the COVID-19 was rolled out, and when the county had to get into the different areas and they used some format like that. I think NPR reported also that in Philadelphia, they had great success in doing such. So that's a fantastic idea.
Thank you.
Yeah, I see questions from Ms. Farrer and then Meriwether.
No questions for me, Marty.
Okay. Pat?
Hi, thank you. And I agree, the faith-based churches and organizations have been really instrumental in increasing the immunizations. Because you are working with children too, I would also work and do outreach with the schools, the elementary schools, the preschools, the kindergartens. Because again, I think oftentimes they have siblings and it's helpful to bring them in as well. This is an area, even the 70%, 73% is still pretty low for many types of immunizations. So again, I think it's good to be compared to others, but I think it's still low as a nation for 73% immunization. I think we should set our goals higher.
Yes, I absolutely agree. So we're hoping to get to that 73%, 75th percentile soon and move it up like we were able to do for our diabetic metric. But I totally agree. I know there's been outreach to the schools, and I'm not sure about preschools, but schools for sure. But again, I think the effort just needs to be more intensified.
Can I ask a question relative to reach out with the school? What do you mean by that? Do we actually go inside and say for one day a week at the beginning of the school year, do we physically set up camp and do we have relationships like that with schools where we can put a clinic inside during August and September to try to get the message out to the parents?
Right. I'm trying to see if anyone from our communications team is on the line. I don't see.
Yeah, Dr. Irons, I'm here. I'm sorry. I'm in the middle of another little mini issue. Can you repeat the question?
I think the question is sort of what are some of the interventions or ways that we can work with the Chicago Public Schools to heighten a vaccine uptake?
Thank you, Dr. Kim. We can do a number of things. We've got a couple outreach actual vendors who have a very deep relationship with CPS, so I'm happy to reach out to them and see where they might be able to take us. I can contact my counterparts over at CPS and kind of put our heads together and see what we might be able to do. But I suspect that if we're going to do it at the city level, we should probably do it across the county. So happy to take a look at it and bring back some specific tactics.
Yeah, this is.
This is,
We'll also be working
this-
with our public health department, only because this is an issue of national concern, that there seems to be a concern being raised about childhood immunizations, their effectiveness, if you need to take them. And so we're seeing these numbers start to become a concern nationwide. And so to avoid falling backwards as a country with the progress we have made, we have to start having a re-education about the importance of vaccination. And so we will be coordinating with our public health department, both at the city and county level, to ensure that those campaigns start to move forward, and encouraging and working with our physicians at every moment to make sure that they're educating and talking about the importance of vaccines. And we will work with partners in the school districts and others, as that's a great area to start, as those are required for a lot of school entry. And so we will continue to work with the school physicals, our school partners, but most importantly, starting early with an education campaign and discussion of how important it is to re-engage vaccinations in our country.
Thank you. Director Harrington?
You're on.
Yeah,
mute,
hear
Dr.
you.
Harrington.
Director Harrington, do you have a question or a comment?
Yeah, it's really more an observation. What occurred to me as I looked at this is our clinic in Inglewood, and there are a number of clinics in Inglewood. So this is representative of work that our clinic is in. I don't know what their patient population is, and so it's low, but it's probably low in Inglewood overall, and we need to keep that in context.
Thank you. I'm in agreement.
And thank you, Dr. Irons, for that discussion. We're going to move forward with several action items, and I remind us that we're going to hold for a combined motion after we go through all the action items. The first one is the additional appointment of Peter Hart as chair of the Department of Medical Staff of the John H. Stroger Jr. Hospital, Cook County, for a term of October 2022 through October 2024. And we have Dr. Kumaplay, the Medical Director of Stroger Hospital, who is going to present this.
Thank you very much. So, after a national search and a rigorous interview process, I'm pleased to report that Dr. Peter Hart was unanimously selected to the future person of our largest clinical department, which is the Department of Medicine, and is very deserving of this promotion.
I'm having difficulty hearing.
Again, okay, let me switch. Can you hear clearer now?
I can hear you. I don't know if maybe
I think the further away from your microphone, then the harder it is to hear you.
Can you hear clearer now?
Yes, now.
Okay, thank you. So Dr. Peter Hart did his medical training in the University of Lagos Medical School in Nigeria. And then he went to England to do further training, including a fellowship in nephrology at the Royal London Hospital. Peter then came to Cook County Hospital in 1993 for his internship. Now, due to his prior extensive training in London, he was granted a waiver. So he didn't need the 3 years, which was required for other trainings. He finished his training in 2 years and then was made a chief resident. Due to his excellence right from his first year, Cook County Hospital then made a big decision to find a way to keep him and a couple of other physicians in the health system. Peter agreed to stay with us and has been with us since he came here in 1993. He joined attending faculty after his chief residency in 96 and carved a path of clinical excellence, educational research, and administrative excellence. Now, Peter has served on several committees in Cook County Health. Notably, he was the chair of our hospital credentialing committee for the past 10 years, overseeing the credentialing of our healthcare providers at Stroger Hospital. And he was very, very instrumental in developing and implementing metrics for our meaningful ongoing professional practice evaluation and the focused professional practice evaluation. He's also really had a big impact on our graduate medical education program over the past 25 years. And he's a nationally and locally recognized clinician educator and diagnostician. Peter, I would say, is easily the most decorated Department of Medicine attending physician over the past 29 years, and he has won numerous teaching awards. The prestigious Department of Medicine Osler Awards was instituted in late 1990s. And after Peter had won the first 3 in a row, a decision was made to not allow anybody who had won to be eligible for winning 3 years later. Dr. Hart also has several publications in peer review journals. With regards to leadership, Peter has served for the past 14 years as our first system chair of the Division of Nephrology and Hypertension for Cook County Health. And he championed and led many initiatives, including developing and establishing the first Providence Hospital Outpatient Dialysis Center, and also creating a peritoneal dialysis program and continuous renal replacement therapy program at Stroger Hospital. Since March 2022, Peter was named the interim Department of Medicine chair. And this came at an opportune time, because then we were making plans to expand services at Providence Hospital. Peter very quickly rallied the Department of Medicine physicians who were going to provide a significant part of the subspecialty care in Providence, and they believed in him. We were able to expand the services there, the number of beds was able to open our ICU, and also when it came to resume our ambulance runs, again, we needed our subspecialists to be on board, and Peter led that charge. Dr. Hart checks all the 4 boxes to be an instrumental and effective clinical department chair in the 21st century. You need to be a visionary and be business-minded. You need to be an excellent diagnostician and clinician. You need to be a renowned clinician educator, and you need to be an avid researcher with numerous publications. I would also like the record to reflect that Dr. Peter Hart is the first Black to be named chair of the Department of Medicine in the 180 years plus storied history of Cook County Hospital. This is the end of my presentation, and I'll take any questions now.
Thank you, Dr. Kumuplay. This is a very comprehensive description, and we appreciate your time. We are going to wait for a combined motion at the end of all of our action items. Next, we're going to turn to Dr. Akintoran, who will present the Stroger Hospital medical staff action items for committee consideration. He'll also present the Stroger Hospital Quality Committee summary for committee information. Dr. Akintoran.
Yes, thank you, Dr. Kim and directors. I am presenting for your consideration the report of Stroger Hospital Credentials Committee, which was received and approved by the executive medical staff at the October 11 meeting. This is the list of medical staff appointments, reappointments, and changes. Thank you. If there are no questions about that, I will just go right on to the summary report.
Thank you.
Thank you. So this is the summary report of the Stroger Hospital Quality Improvements and Patient Safety Committee, based on the meeting and the minutes of the meeting of August 23rd. The highlights: patient safety, under patient safety heading, reported safety events for August 2021 to July 2022 was 45, and this is lower than the 4933 number from a year earlier. So there was a 10% drop. in that period compared to the previous period. Also, reported safety events with serious harm was 0 compared to the same period in the previous year where there were 5 events. So that's a really big achievement there. And the actual number of any serious safety event was 0 for June 2022. The serious safety events were reported to that meeting actually were related to patient coordination, and we are paying close attention to discharge planning because that seems to be where those problems are coming from. Then regarding nursing, Dr. Peters did give some updates there. But the HAPPY prevention project was very successful with a happy ending, and of course those efforts to keep that down, it's ongoing. The PSI grade 3, grade 4, which are the serious ulcers, has been 0 from January to July of this year, and above the 45th percentile for the second quarter of 2020, above the 45th percentile since second quarter of 2020. The catheter-associated urinary tract infections have been reduced from 16 in all of 2021 to just 6 in 2022 for that period of January to June of both years being compared. Class B for the first quarter of 2022, Class B rate per 1,000 patient days was 0.34, which is at the 50th percentile. For pharmacy, environment of care rounds in pharmacy shows 100% compliance in June 2022 and July 2022 for medications secured, high alert medications labeled properly, vaccines done properly, and dating of multi-dose pairs. Insulin being compliance was 88% in June, 93% in July 2022. The goal is 95%. So we are rapidly approaching that goal. Same for medication barcode scanning compliance. It was 93% in June, 93% in July 2022. The goal being 95%. There were no action items for the EMS committee, and there are no action items for the QPS before you today. Thank you.
Thank you, Dr. Akinturan. I don't see any hands up. We're going to move forward with Dr. Mark Loafman, who's going to present the Provident Hospital medical staff action items on behalf of Dr. Marlon Kirby for the committee's consideration, and also he will present the quality committee summary for committee information. Dr. Loafman?
Yeah, thank you, directors, colleagues. It's a pleasure to be here to report out today. I am in clinic, so there's a little background noise. I apologize for that. We're doing our best here. So I think you see the QPI, the Quality Performance Improvement Committee report. We do need to meet monthly. I'm really proud of the work that's being done at Provident. You can see some pretty significantly high performance rates on the metrics, and I will say we have a lot of the quality department has helped push to get some stretch goals. So these are not easy slam dunk measures by any imagination at all. So no hospital acquired pressure injuries, no CLABSIs or CAUTIs, so no line associated infections for all of 2022. And that is in spite of the increased census and the growing and expansion there. We continue to see really good nursing performance with these measures. So that's just, congratulations to the staff and all that's going on. The ED nursing, if you may recall, one of the Joint Commission findings. It was a low-level finding when they were here a while ago, and our otherwise very good Joint Commission's survey that we had was an issue just with the way we were documenting that IV fluid, irrigation fluid was being kept in the warmer. They didn't find a problem with the way we did it, but our documentation about it. So that's been 100% for several months now, and we only had that as a just a remediation report. So we have recommended the ER that they continue the tracking that they're doing, but they don't need to report that to us any longer. Length of stay continues to be a stretch goal for the ER. It was a little bit better in the reporting month here for August, and that's great. We talked a little bit about things that make it better, make it worse. We of course want to keep an eye on that as we expect volume to come up with the recent changes, and I think it will continue to be a stretch goal for the ER to look at how to process. 3 hours is sort of the industry standard at 180 minutes. It still seems kind of long for minor patients, so that sort of an average of 180. Obviously somebody with a minor injury or minor complaint should be able to get out even faster. And then moving to infection control, Trophon is that's the disinfectant used for probes, as I'm sure you're all aware. We report on this pretty regularly, and there were some concerns, again, mostly with the way we were documenting the process to get that reliability with the ultrasound and the vaginal probe, and that's been consistently at 100% also for several months. So the processes are reliable there, and kudos to the team for that. And the last one, which is, you see how hard it is to get hand hygiene compliance, at 100%, and we have an infection control nurse at Provident who really has been hounding this for years and watches it and coaches on it, and we continue to see very good success with that. And it's just making sure that people are caught doing it. I think some of the struggle is people may go into the room and they're not observed doing the hand hygiene. You don't know it's done unless you see it. So I think the Provident staff have all been coached enough to know that they want to do their hand hygiene compliance in a way that's visible to the public and the patient. So that's obviously what's happening here. I think there were no action items for EMS, so we just did a brief summary for them, and then the QPS committee, we're continuing to work on trying to tweak and stretch goals, and really with the PDSA, the Plan, Do, Check, Act cycles, to help each of the units that report to do more innovation, to do more integration with staff, so that they're making sure that they are studying and evolving these metrics as they move forward. So that completes my report.
Thank you, Dr. Loafman. I don't see any questions or hands raised, so we're going to move forward. You received the September 23 CCH QPS minutes. These were approved by the board at the September meeting, but are being presented to the committee today for review and discussion if necessary. Please let me know, because we can still make corrections if we need to the minutes. Okay, we're going to move forward. I'd like to entertain the following combined motion to approve. Approve item 4A, a proposed Stroger Hospital Department Chair, the initial appointment. Approve item 4B, Stroger Hospital Medical Staff appointments, reappointments, and changes. Approve item 4B, Provident Hospital Medical Staff appointments, reappointments, and changes. And accept item 4C, September 23 CPS QPS meeting minutes.
So moved.
Seconded.
The combined motion has been made and seconded. Thank you. Madam Secretary, please take the roll call vote on the combined motion.
Roll call vote on the combined motion. Aye or nay, Director Garza?
Aye.
Director Prendergast?
Aye.
Director Story?
Aye.
And Chair Kim?
Aye.
So you have 4 yeas and 0 nays.
Okay, the ayes have it and the combined motion carries. Thank you. The committee will now be going into closed session. Action is not anticipated to be taken in the open session after the closed meeting has adjourned. I'd like to entertain a motion to go into closed meeting pursuant to the following exceptions to the Open Meeting Act 5 ILCS 120-2, C 1, 11, 12, and 17.
So moved.
Seconded.
The motion's been made and seconded. Madam Secretary, please take the roll call to vote on the motion.
Roll call vote on the motion to go into closed session. Aye or nay, Director Garza?
Aye.
Director Prendergast?
Aye.
Director Story?
Aye.
And Chair Kim?
Aye.
You have 4 yeas and 0 nays.
Great. The ayes have it and the motion carries. So we will now go into, I declare this meeting adjourned and we will go into closed session.
Madam Chair,
Yes.
the open session remains pending until we come back out of closed session.
Okay, I'm sorry. We will go
Okay,
into
sorry.
closed session and then come back. Thank
That's
you.
it. Thank you.